Um, Martin, you are the lead for the TB service at Birmingham Heartlands Hospital. Is that correct?
Yes, in the ID department. Yes.
Okay, and I believe that you worked in Africa for about 9 years, and you were looking after quite a number of TB patients there.
Yes, that's right. I mean, the incidence of TB in South Africa is about 1,000 per 100,000. So that's 1% of the entire population get TB every year. And in comparison, in the UK, the incidence is around 5 per 100,000.
Right, so really quite a striking difference.
Yes.
Just tell us, what is TB?
Okay, well, TB is an infection caused by a bacteria called Mycobacterium tuberculosis. The bacteria is usually inhaled, and it usually causes a lung disease, but it can cause disease at various sites. It can give you a meningitis, it can give you a disease in your spine, it can give you a disease in your joints or in your glands. It can give you a disease in your abdomen or in your heart. It can affect most parts of the body.
Okay, and is it fatal?
Untreated, and certainly in someone that's HIV infected, TB is very often fatal.
Okay, you mentioned they're HIV infected. Is it something that you see quite a lot, HIV and TB together?
Okay, well, certainly in South Africa, the HIV epidemic has caused a huge increase in the incidence of TB. If I give you an example of the hospital I was working at, in 1991, the HIV prevalence in the antenatal population was 0.5%, and in that year there were 300 cases of TB. In 2002, the HIV prevalence in the antenatal population had risen to 30%, and the number of TB cases seen in the hospital was 4,000, so from 300 to 4,000, and that was almost completely driven by HIV, because those TB patients, 90% plus of them were also HIV infected.
So there seems to be something about HIV and TB co-infection. Can you talk a little bit more about that?
Yes, well, TB is a disease that is very often controlled to some extent by your immune system. And very large numbers of people in the world, in the billions, are infected with TB, but that TB is dormant within them, and it will only turn into a TB disease if their immune system should become damaged. Now, unfortunately, as we know, HIV damages the immune system, and it specifically damages the cell-mediated immune system, which is the bits of the immune system that keeps TB in check. So if you acquire HIV and your immune system is damaged, it's very likely that TB inside you will reactivate. And also, if you're exposed to TB and you've got HIV, you won't be able to handle it and control it. It will turn into a full disease, as opposed to something your body could either clear or control.
I see. And is there any other effects? Does HIV make TB progress faster, or does it make it any more aggressive?
It probably makes it progress much faster.
Okay. And what about the other way around? Is there any effect of TB on HIV?
Yes, there is. When you have a chronic infection, your viral load, your HIV viral load, which is the amount of virus inside you, can rise. And if your viral load rises, the amount of damage your immune system suffers increases. So TB as a chronic infection is an example par excellence of this. It pushes your viral load up, and your HIV disease progresses more rapidly.
I see. Are you able to treat both of those conditions?
Yes, both are eminently treatable, and they must both be treated together. I mean, one of the big problems that people had initially in places like South Africa is TB patients weren't getting tested for HIV. So if you treat someone's TB and you don't diagnose and treat their HIV, you will help them in the short term, but not in the long term. But TB treatment is readily available in the whole world. It's usually free. It's free in the UK. It was free in South Africa. It's a 6-month course, and if someone takes their treatment, the cure rate is way over 90%.
Right. Are we seeing, just coming back to the UK, do we see a lot of TB in the UK?
Oh, in the UK, the incidence of TB is about 5 per 100,000 per year. In Birmingham, the incidence is 13 per 100,000 per year. That equates to about 1,000 cases of TB per year in Birmingham.
Okay. And is it in any particular ethnic group that you see TB, or is it just across the spectrum?
Well, everyone's susceptible to TB. Anyone can catch it. It does tend to be higher in certain ethnic groups, And the prevalence of TB in a certain ethnic group tends to reflect the prevalence and incidence of TB in the country where those people are from. So amongst, for example, Africans in Birmingham, the incidence of TB will reflect the incidence of TB in their home country, which is much, much higher than the UK, so that they tend to have a higher incidence.
Okay. And is it predominantly Africans that are getting TB in Birmingham?
Well, in Birmingham it's a mixed picture. The majority of TB is in people from the Asian subcontinent, so specifically Pakistan, India and Bangladesh. But a large proportion, not the majority, but a large proportion are also from sub-Saharan Africa.
Okay. I've heard about drug-resistant TB. Can you tell us what exactly do people mean when they talk about drug-resistant TB?
Okay, so TB is treated with a combination of medications, much in the same way as HIV. You can't use one drug because the mycobacteria, the TB, will rapidly become resistant. You have to use a combination of drugs. And we tend to use 4 first-line drugs, which are called rifampicin, isoniazid, pyrazinamide and ethambutol. They're all tablets, and they're all quite easy to tolerate. And they allow us to treat TB in what is now considered a short time, which is 6 months. TB treatment used to be much, much longer before that. Now, if the TB that is taken from someone and grown in the laboratory is not sensitive to those drugs, which means those drugs can't kill it, it's called resistant. And the 2 key drugs are the ones called isoniazid and rifampicin. If your TB strain is resistant to one drug, it's called a monoresistant strain. But if it's resistant to both isoniazid and rifampicin, it's called multi-drug resistant TB. And that is a problem, because if you can't use rifampicin and isoniazid, you have to treat the patient for much longer.
Do we have a problem with multi-drug resistant TB in the UK?
Luckily we don't. We probably have less than 100 cases under treatment at any one time in the entire country. So it's less than 1% of the total amount of TB in the country.
What about other countries around the world?
There is a problem. I mean, the countries that stick out are some of the former Soviet republics. So the countries with the highest instance of both multi-drug resistant and extensively drug resistant TB are Latvia, Lithuania, Estonia, some parts of Russia, the Ukraine, and various hotspots in Africa. South Africa is one of those.
In those countries, those former Soviet states, do they also have problems with HIV, or is that unknown?
No, HIV unfortunately is also prevalent in those places, mainly amongst prison populations and intravenous drug users, which unfortunately are the same people who are getting the multi-drug resistant TB.
And hepatitis C?
Hepatitis is a problem in those countries.
Right, okay. How infectious is TB?
Okay, well look, it's quite infectious. It's less infectious than some of the STDs, it's less infectious than something like flu, but if you're exposed to someone with open TB, that means someone that's coughing out bacteria, you stand quite a high chance of catching it.
So if I was on the bus with a person who coughed, I would get TB?
No, not necessarily. You probably need a longer exposure than that. I mean, when we have someone when we diagnose someone with sputum positive TB, that means TB where we actually find it in their sputum, we class them as an infectious case and we do contact tracing. And the people that we trace are people that have had close contact with them. So that's usually people that sleep in the same house.
Okay. And when you find these people, what do you do to them?
Well, first of all, we determine if they've got active TB. So we sit down and talk to them, we examine them, we take a chest x-ray. If they don't have active TB, we monitor them for a period of time and carry out further tests to see if there's any evidence they've been exposed to TB.
Okay, and how do you do that?
Well, we've got 2 tests available to us. We can do a skin test, which is called a MAN2 test. That's where you inject a small amount of protein into the top of someone's arm, and you watch to see if there's a reaction. And if there is a reaction, that shows that person has been exposed to TB. We also have a blood test called it's called an IGRA test, and that tells us if people have been exposed to TB as well.